Good afternoon. It's good to be here. I'm going to have everybody stand up and stretch. I'm a registered nurse and I work in an emergency room, and I worry about those veins and those clots. So everybody stand up and stretch if you would. You're moving slow. I'm going to make you do jumping jacks. All right. Okay. Thank you. So I'm really pleased to be here today, and I'm just amazed at the amount of energy and the amount of resources that are going into the work of this conference and what's going on in the entire European Union. I'm going to come at things a little bit differently this morning. Like I told you, I'm board chair of HL7 International, which is a standards development organization, of which you had one of the introductory speeches this morning was from the individual who is the chair of HL7 Hellas. That's work that I do, part of my work. But in my day-to-day work, I am a nurse in the emergency room. I work in a large hospital in the U.S. on the western coast, the state of Oregon. And so the topic I'm going to talk about today is the International Patient Summary. And you've heard this mentioned throughout the morning from the different speakers. It is near and dear to me because we get folks in internationally. In the city in which I live, Nike is headquartered. For those of you who wear Nike apparel, Adidas has a headquarters there. Intel has headquarters there. We see a lot of international traffic in our emergency rooms. But we also see a lot of people who are right there in the community who arrive to see us, and we're clueless on what's going on with them. We have absolutely no information. And as our population ages and we get more and more people who have dementia and Alzheimer's, who are isolated from their families, they come into us maybe because of a wellness call made to the social services, and they show up and we know nothing about them. So something that would give us a leg up in how to take care of them and best take care of them while we're trying to do the right thing at the right time and not expend more resources than we should be for that individual, but making sure we expend what they do need in order to maintain their health is really important to us. So let's talk today about this International Patient Summary. So how many of you are familiar with the Trillium Bridge project? Any? I see a couple of hands. Yep, there's some more. Okay. So Trillium Bridge was a project from 2013 to 15, which was actually, it was between the U.S., the Office of the National Coordinator, and also the European Union to look at what we could do to interchange information across the Atlantic. And it was really a demonstration project to see what information we needed. It was limited to elements like problems, medications, and allergies, but it was put in place to help identify gaps because we knew that the U.S. had a number of projects on patient summaries going on. We knew that the European Union had a number of projects going on. A lot of people doing a lot of different things, all with the very best intentions, all with wonderful use of resources, but somehow we still weren't able to connect and communicate. So this, over 2013 to 2015, this project was kind of socialized, if you will, through HIMSS, through IHE Connect-a-thons, through eHealth weeks here in Europe. And when it was all said and done, and there was records flowing back and forth across the Atlantic between 4 countries and Kaiser Permanente, they finally came down and says, hey, is this worth it to go further? And should we really try to do something that's really more standards-based to maybe really facilitate the flow of information? So that was Trillium Bridge, and out of that came a recommendation that was basically, yes, move ahead on this thing. And we need to give people the ability to access and to share their information. So here comes that person that you've heard talked about so much this morning. And oh, by the way, that person is each one of us, because each one of us does participate in healthcare, no matter how healthy or ill we are. And they said, go further. Don't just talk about allergies and medications. Give us more information. Tell us about immunizations, past operations, implants, and things of that nature. So out of that then was born the International Patient Summary Project. And this is an HL7 and a SEN based project. And there was an agreement signed between HL7 and SEN formally again in April of 2017, but the project actually began back in 2015 when Trillium Bridge was winding up. The vision of this project is to collaborate on a single international patient summary, and the scope was to keep it tailored down to, guess what? Those who need emergency care, much like it was talked about by the first speaker of this group, emergency care or other unplanned care. So keep it narrow in scope, but make it really very broadly based. The development principles of the project are really terrific, I think. From a top-down perspective, we wanted the direction, and we need the direction from the countries, from the governments, from the organizations to say, what is it that we need, and keep the scope of the project to be what's really going to help them formulate, if you will, a building block. And then from the development organizations, what we need is a bottom-up approach of don't reinvent the wheel. If there's stuff out there that you can use, use it. If it needs to be modified, modify it. But use what you have to try make use of what is known to be out there to try to make the project be developed most effectively. This project is, and we've heard about this morning too, the need to cooperate on many levels. So it's really a cooperation of groups of experts that include the private and public sector as well as academia. It's a collaboration by standards development organizations. Like I said, there's SEN, ISO is also involved in this, as well as IHE. The governments, again, the U.S. via the Office of the National Coordinator and the European Commission. The government involvement is so important in this. You know, in the U.S., when we hear what the government's up to, that's what we start developing our plans around, and that's what we talk about as we are trying to figure out where to prioritize what our work is. Knowing what the governments want and being able to have an active dialogue with the government officials, whether it's regional, whether it's local, or whether it's national, is so important to try to get the right things in place the first time around. Because things are moving fast. We don't have the next 50 years to figure out some of this stuff. We need to be putting our feet in place at the right time. And then, again, a lot of involvement from the European HL7 affiliates, keeping in mind that there's been a lot of work done in Europe already. So we know, for instance, and it's been mentioned in some of the other presentations, there is an international patient summary project, and that the EU has been very, very involved with. So one of the charges within this is to make sure that we are not leaving that in the background, but that we're considering this, knowing that we've got holes and gaps that we need to fill. But that's part of the work. That's part of the fun and the challenge, is to figure out how to solve the issue and solve it in a way that is small and that can be done. One of the things I really like about this standard that's being developed, and we'll look at it a little bit more in just a minute, is that it requires us to identify the specific clinical data that is needed. In so many implementations, and I've implemented standards for the U.S. government, they happen to be the X12 standards. But there were gaps in understanding exactly what that data element was. It wasn't defined anywhere. It wasn't tabulated. So taking this down to the exact clinical data and understanding what the vocabulary binding needs to be and what the value set is. So when that piece of data flows across the border, when I get it, I can understand, because of how it's tabulated, exactly what's talked about there. I may not be able to understand seeing a word in Greek, but I can understand if we are both exchanging LOINC codes, and LOINC codes mean the same thing, I know what I'm getting. They wanted us to build an international document with templates, so published templates, so somebody doesn't have to go out and create this stuff on your own, but it comes to you as a package when somebody wants to implement and play with this. It comes as a package to be used. Using existing standards, so clinical document architecture that from HL7 is one, and certainly FHIR is suggested as being another architecture that we would use. Limit the use cases to emergency care and to unplanned care, and then make sure that things are conformant, because again, when things move around, if they don't mean the same thing when they get to me as what you sent when you sent it, then we're in trouble. You know, we need to be able to understand these things when they hit us in an emergency room. And it doesn't really matter whether it comes to me electronically, whether somebody carries it in on their thumb drive, or whatever media it shows up. What's important is that I'm able to understand it. So what we've developed out of this joint project is an implementation guide. And this thing went to Ballot, and this is the formal name of it, the HL7 CDA R2 Implementation Guide for International Patient Summary. And it was published for Ballot for September of 2017, so just last month. And it is what we call a standard for trial use ballot. It's not available to all of you at this point. We're going through the Ballot comment reconciliation process right now, but when this actually gets published as a standard for trial use, the HL7 standards are freely available. And you'll be able to go into that website and download this guy and look at it. Again, it's intended to be very specific, so it's easily implementable. At the beginning, we talked about how the Trillium project had limited number of sections, and the recommendation was to go beyond. So things like advanced directives, the number of times somebody comes into my emergency room and we don't know what to do with them. They're very ill. We don't know if they've got Alzheimer's. We don't know if we need to be doing CPR in them. We don't know it. We look at them, we think, I think you're sick and I think you're on your way out. But we don't know what their wishes are. So that's really, really important to know. Allergies and intolerances. I need to know if what I'm going to give you is going to kill you, or if it's just going to make you sick to your stomach. Okay, really important. Functional status. Am I wheelchair bound? Do I require a cane? What is my basic function, so that I know when I try to get you up on the side of the bed what I can expect? And certainly the history of past illness, pregnancies, history of procedures is good information to have. Immunizations is critical. Medical devices. So we had a guy come to us and he had chest pain. And we said, we were trying to figure out what was going on with him. We went for x-ray. He comes back. He's got this piece of metal in his chest. Well, where'd you get that? Well, I had surgery in South Africa 3 or 4 years ago. Yeah, what'd they do to you? Well, you know, I had trouble with my aorta. It was splitting, so they replaced this piece. And it's got metal in it. And, of course, we wanted to do an MRI because of the set of circumstances that were unfolding. But we were afraid to put him in the MRI machine because we didn't know what metal this was. We didn't want to rip this thing out of his chest when that big magnet hit him. So this is a really wonderful instance of where somebody had traveled around as part of his work, had had major health issues, and had been wonderfully treated and was in great health today, but we didn't know where to go with him next because he didn't know where he had been. He didn't know what he had had. His records were at home someplace, and something like a summary that carried that information forward would have been so terrific for us in how to best take care of him. Medications have been mentioned earlier, so critical, not only past but current medications. A plan of treatment, problem list, results, and social history. These are all the different sections that were agreed upon when this group got together to develop this. And just so you know who was involved with the group, there had broad representation. So there were representation from Italy, Germany, France, the UK, Austria, Australia, Greece, of course, and the US. And so broad representation to bring this together as we develop this international standard. And this is an example of a CDA rendering of this standard today. Again, it's very, very tightly put together. You have to really fill out whether you don't know something or whether something is not applicable. So we're not left with a bunch of blanks on the receiving end saying, I wonder what's really going on with this person. So, and you can see here it's rendered for human readable, but certainly you could have it be machine readable, so you could import it to whatever system, like the example of the runner in Britain with diabetes who was in a world of hurt, and it could be imported theoretically into an electronic health record. It's a window to the person's health. Okay, this is not a replacement for an electronic health record, but it is a window to the person's health. It is designed to support a community, but also global needs. It develops and has the opportunity to develop an innovative ecosystem, not limited to just one tiny area of the world, but the opportunity to be very broad-based. And it allows for the exchange of human and machine-readable health, clinical, management like insurance information that might be perceived or pertain to the individual at hand. The document that is being balloted right now is being balloted just for those different sections and what was required in those sections. And it is not intended that it would be just limited to that. That's one of the things that standards really gets a bad name for, is they end up for one thing and only one thing, and you can't do anything else with them. We need to change that understanding and the way that we create standards so that they can be, in fact, used, fed back on, and updated as they need to, maybe in general and maybe specifically to a country need or to a country philosophy. So the principles include that it's implementable, truly implementable, that it's applicable for global use. And since we've published this, we've had interest from the countries of Korea, HL7 Korea, as well as HL7 Singapore, who are looking at joining the group to implement this. It needs to be extensible and open. You can see it, you can see what it does, you can write extensions to it without affecting the base standard or the base implementation guide, and it needs to be sustainable. This is just kind of a visual, if you will, of the development of requirements, the design and implementation that shows, again, that there's a lot of people involved in this. And there's a lot of companies, a lot of organizations, a lot of countries that need to come together and will continue to come together, and it's not exhaustive, that to make this kind of work not only valuable, but seen as needed in order to continue working together. So I said that the document that was prepared with all those sections went through ballot reconciliation, or went through ballot this past summer, which means the document was written, it was put out there, and we asked people, whether you were members or not members of HL7, what do you think? What's right with this? What's wrong with this? Where are we not being clear? What do we need to add to it? Those types of things. And we got comments not only from all the countries that I'd mentioned had participated, but in addition, we heard from the Netherlands, from Poland, from Norway, from Canada, and from Finland. All of these countries interested in looking at these documents to say, you know, we might be We weren't involved in the first blush of this, but we're certainly interested in participating in knowing that it's going to work. We hope to publish the standard for trial use in early 2018. So we'll get through these comments, we'll enhance the document in order to meet the comments and go back to the commenters and make sure that we've met their needs, and then bring that standard for trial use forward for publication in early 2018. That's when you guys can get your hands on it, and get your hands on it through the HL7 website. We will be looking for implementers. We've already had some people stand up to the plate, but we're looking for implementer feedback, and that's the purpose of a standard for trial use. Put it in place, work it, try to work out the kinks. What's real about this? What isn't real about this? And that's where various country requirements that hadn't been brought up forward before will come forward. Like, you guys, we didn't think about it when we developed it. We didn't think about it when you had comments. But now we're using it. The rubber's hitting the road. This is how this thing really needs to change in order to be applicable in my country or in my region or in how I do my work. And then we need to get into a phase of updating that standard so that it's implementable. It's not something that acts like a bunch of popcorn jumping around, but that you can count on what it is and when it's going to be refreshed for further implementation if you want to do that. So in summary, this international patient summary, and I've heard this from, I think, almost every speaker this morning, this patient summary, this standard is intended, again, with broad input to meet the needs at a base level across many sections of many countries, so that when it's handed off from one country to another, or within a country or within a community, that the individual who's the subject of has had some opportunity to participate in that it meets the needs like privacy and security of what that country is experiencing, and we're able to get the information into the hands of the caregivers who are trying to take care of that person. It's an opportunity to be a really global standard. It's an opportunity to add this to our discussions every year as we go on here. There's a lot of hard work. It doesn't happen as fast as we'd all like it to, but it is a lot of hard work, and it gives us the opportunity not only to learn about how different countries are regulated, but also how we can work together and how we do healthcare together. So thank you for your time. I hope that's a little bit different cut, if you will, than and more specific to the International Patient Summary than some of the presentations you've been hearing. But it is near and dear. I can tell you, as a healthcare provider, I'm looking forward to getting this in my ER when somebody comes in. Thank you.